Hello everyone. Let's discuss about gallbladder and biliary system. We'll start with the question. We have a 22-year-old man who comes to the clinic with complaints of 6 weeks history of intermittent abdominal pain. The patient states the pain was more prominent on the right upper quadrant, which typically occurs after the meals. There was a history of his spleen removed at his young age. The vitals were stable. On physical examination, there was mucosal pallor and scleral icterus. Which are the following is most likely cause of in this patient's condition? Now the uh, pattern involves giving a clinical scenario and asking you to arrive at the diagnosis. These questions will be lengthy, so always try to underline important questions. Okay, we'll come to this slide, this question in the subsequent slides. Uh, Gallbladder actually develops from the primordium liver from around third week of intra life from the caudal end of the foregut. Liver and the gallbladder develop from the caudal end of the foregut. Hence, they are supplied by celiac trunk. Okay, you should know of the arteries of the foregut, hindgut, and midgut. Okay, this primordium liver elongates cranially and gives a small bud on the right side, which develops into pars cystica, which is future gallbladder. Pars cystica becomes gallbladder in the future. Okay, and main part gives pars hepatica, which becomes liver proper. Usually, gallbladder measures around 7 to 10 centimeters long and it is 3 centimeters broad. It is pyriform shaped or pear shaped with sea green appearance. Usually, gallbladder can hold up to 30 to 50 ml of bile. But there are instances that where a gallbladder can hold up to 300 ml of bile. Parts of the gallbladder includes fundus, the body, and a tapered portion of the body that connects body with the neck. Okay, this tapered portion is called infundibulum, and neck is connected to the cystic duct with aqua diverticulum called as Hartmann's pouch. And does gallbladder has any valves in it? No, gallbladder doesn't have any valves. But the valves are present in the cystic duct. These valves are called as valves of Hester. These are all mucosal folds. They actually, what is the function of these valves? They help in prevention of passage of the gallstones into the CBD. Okay. And is there any sphincter that is present in the cystic duct? Yes, there is an ill-defined sphincter that is called a sphincter of Lutkins that is present in the cystic duct, but it is not as well developed as the sphincter of Odin. Okay. Mm. Coming to the histology, as you know, gastrointestinal tract has four layers. It is made up of mucosa, mucosa has three layers again: epithelium, lamina propria, muscularis mucosa. And this is mucosa is followed by submucosa. Submucosa again is followed by muscularis propria. It has two layers: outer, inner circular, outer longitudinal. Just remember these things. Okay, inner circular, outer longitudinal. You should not make mistakes in these kind of basic questions. And there is serosa. What is specialty? What is the variation that is seen in the histology of the gallbladder? Gallbladder is in the gallbladder doesn't have muscularis mucosa, and submucosa. Hence, it also doesn't have Meissner plexus. Meissner plexus are located where? They are located in the submucosa. And where are the Arbach plexus are located? Arbach plexus are located between the inner circular, outer longitudinal muscle layers in the muscularis propria. What is the function of Arbach plexus? They help in peristalsis. What about Meissner plexus? They help in secretion, villus secretion, and other things. So in gallbladder, there is absence of submucosa, there is absence of Meissner plexus, and there is absence of muscularis mucosa. Okay, and coming to some important anatomical aspects, the related to surgery with respect to gallbladder are they have mentioned about some triangles. They are hepatocystic triangle and Kellogg's triangle. Some say they are same, but which is not the case actually. Hepatocystic triangle is a larger triangle. It is a larger triangle. As the name indicates, it is bounded by inferior surface of the liver on one side, common hepatic duct on another side, and the third side is made up of cystic duct and gallbladder. Okay, so the three sides of the hepatocystic triangle are inferior surface of the liver, common hepatic duct, and cystic duct and gallbladder. Okay, what is the content of this hepatocystic triangle? The content of this hepatocystic triangle is cystic artery. Cystic artery is a branch of right hepatic artery, which is again a branch of common hepatic artery, which originates from celiac trunk. What about Carrot's triangle? Carrot's triangle is a small triangle inside this hepatocystic triangle. Okay, Carrot's triangle is a small triangle inside this hepatocystic triangle. This is actually bounded by common hepat three C's. Okay, remember it as three C's. It is bounded by common hepatic duct on one side and cystic artery on another side, and cystic duct on the third side. Okay. What is the content of this Callout triangle? The content of the Callout triangle is cystic duct, cystic lymph node of Lund. Okay. Whenever there is any pathology involving the gallbladder, there will be reactions or enlargement of this cystic lymph node of Lund. Okay. Okay, coming to the functions of the gallbladder. The main function of the gallbladder is it acts as a reservoir of the bile. Okay. So, when it is acting as a reservoir of the bile, it concentrates the bile. There was an MCQ asking how many times the gallbladder actually concentrates the bile. Usually, gallbladder concentrates up to 5 to 10% of the bile. Okay. And there is acidification of the bile in the gallbladder. Gallbladder also secretes mucin. Okay, and whenever there is any kind of abnormality with mucin production or something, then there is development of mucocele. This condition we'll see in the subsequent slides. Coming to the congenital anomalies, the most common congenital anomaly, if there is any question, which is the most common congenital anomaly that is seen in the gallbladder, we should say it as Phrygian cap. It is actually Phrygian cap. Usually they used to wear it during the French Revolution. It is an infolding. It is infolding between the body of the gallbladder, between infolding of the body of the gallbladder and fundus. Between there is infolding between the fundus and the body of the gallbladder. For these patients, do we need to perform laparoscopic cholecystectomy? Any patient with Phrygian cap, you don't have to perform laparoscopic cholecystectomy unless and until there is involvement of any other pathology. But which is the most dangerous anomaly seen in the gallbladder? See, usually right hepatic artery runs towards the left of the common bile duct, goes posterior to it, and gives cystic artery branch. So in this Moynihan's hump or caterpillar hump anomaly, what happens is this right hepatic artery runs very close to the gallbladder and cystic duct. So while performing surgery, we may confuse this right hepatic artery as cystic artery, and if it is clipped, then there will be grave consequences. So what is the composition of the bile? Bile is actually made up of 95% of water, and the rest 5% is made by cholesterol, bile acids, and lecithin, phospholipids. Okay. So whenever there is any abnormality in this homeostasis of these three things, for this 5% cholesterol, bile acids, and lecithin, then there is formation of the gallstones. Okay. As what in the bile actually, as cholesterol is lipid soluble, it is made water soluble by this bile acid and lecithins by the formation of the micelles. If there is any abnormality, then there is development of the cholelithiasis, gallstones. Gallstones are crystallized deposits in the gallbladder or within the biliary tree composed of cholesterol, bilirubin, and bile. There are types of gallstones. The types of gallstones include cholesterol stones, pigment stones, and mixed stones. There have been multiple MCQs asking MCQs regarding. They have asked like which is the most common gallstone seen in the world. Which is the most common gallstone seen in the world? Among these three, the most commonly seen gallstones in the world is mixed gallstones. Okay. What about Asia and India? Pigment stones are most commonly seen in Asia and India. What is the main pathology in the development of the gallstones? The main pathology in the development of the gallstones is nucleation of the cholesterol monohydrate crystals from the multilaminar vesicles. There is nucleation of the cholesterol monohydrate crystals from the multilaminar vesicles is a very crucial step in the formation of gallstones. There are three factors in the development of the gallstones. Okay, there are three factors in the development of the gallstones which involves lithogenic bile. So as I said, the bile consists of water 95%, cholesterol bile acid and lecithin makes up another 5%. Whenever there is any abnormality like elevated cholesterol or low bile acids or lecithin, then that particular bile is called as lithogenic bile because it is leading to the development of the gallstones. So, three factors that are important in the pathogenesis of gallstones are lithogenic bile, enucleation of the cholesterol crystals, and bile stasis in the gallbladder, if there is gallbladder stasis. Okay. So, what is lithogenic bile? Whenever there is increased cholesterol, bile cholesterol, in conditions, where do you see increased bile cholesterol? If patients with obesity, cholesterol-rich diet, if at all they are taking, patients on clofibrate therapy, these patients have rich cholesterol. Okay. And whenever there is decrease in bile acids, what happens is most of the bile is actually enter whatever that is secreted into the small intestine, it is going back to the liver through enterohepatic circulation. In a 24-hour cycle, how many times enterohepatic circulation actually occurs? It is actually around 6 to 10 times. Okay. So the most of the bile acids and B12 vitamins are usually absorbed in the terminal ileum region. So whenever there is any condition that is affecting the terminal ileum and any resection, so in these conditions there is hampering in the absorption of the bile acids. So there is decreased bile acids leading to the formation of the lithogenic bile. Okay. And certain patients with obstructive jaundice, cirrhosis, these patients are given some drugs such as cholestyramine, cholestypol. They actually are bile sequestrants, so they help in excretion of the bile. Because these patients, obstructive jaundice patient, they will have itching, too much of itching. When these cholestyramine, cholestypol are given, these drugs help in itching. Okay, so they help in excretion of the bile acids. So there is fall in bile acids. Whenever there is biliary lecithin decrease, such as some MDR gene mutation conditions, then there is development of the lithogenic bile. The second aspect in development of the pathophysiology of the gallstones is nucleation. When there is any abnormality in increased pronucleating factors such as any infection, mucin from the gallbladder, then there is formation of nucleation of the gallstones. And when there is fall in the antinucleating factors such as apolipoprotein A1 and A2, then there is chance of formation of the gallstones. So coming to the stasis of the gallbladder, which is the third factor in the development of the gallstones. Usually what happens is whenever we take high fatty diet or high fatty diet through oral route, whenever you're taking oral route, there is production of this cholecystokinin. Cholecystokinin is produced from the eye cells in the proximal small bowel. Okay. And its counterpart is secretin, that is they are produced from the S cells. Okay. And whenever we take food orally, high fatty diet, cholecystokinin is produced, which helps in contraction of the gallbladder. Gallbladder contracts, and there is relaxation of the sphincter of Oddi in the duodenum. So, and this is followed by production of gastrin, and there is delayed gastric emptying. You would have noticed yourself whenever you have high fatty diet or when you have consumed non-veg and all, you don't feel hungry for longer duration. That is the reason why, because there is delayed gastric emptying. So this is the normal pathology normal physiology that occurs. Okay, when you take food orally, high fatty diet, cholecystokinin is produced. But in conditions where there is prolonged fasting and there is a need for prolonged TPN, total parental nutrition, this cholecystokinin is not produced because cholecystokinin is produced only when you take food orally. And in conditions with vagotomy, actually the parasympathetic system is activating. Actually, it increases the peristalsis in the bowel. But whenever there is severance of the parasympathetic system, then there is stasis of the gallbladder. And in conditions with pregnancy and OCPs, what happens in pregnancy and OCPs? There is elevated estrogen levels. Estrogen has relaxing effect on the gallbladder. Hence, then it's stasis of the gallbladder. Coming to the types of the gallstones, cholesterol stones are most commonly, if at all it is, if mixed stones are not given in the option, you should choose cholesterol stones are the most commonly occurring gallstones in the world. Okay, and these cholesterol stones are most commonly seen in the Western countries. These are made up of 100% cholesterol stones. But pure cholesterol stones are seen in less than 10% percent patients. Okay, cholesterol stones are solitary and soft, and they are usually radiolucent. The MCQs regarding this also. All the gallstones, 90% of the gallstones are radiolucent, except 10%. And the 10% are radiopaque. What about renal stones? 90% of the renal stones are radiopaque and 10% are radiolucent. What about salivary glands, salivary gland stones? Salivary gland stones, 80% of the salivary gland stones are radio opaque, 20% are radiolucent. These are all MCQ that are asked. Please make a note of them. Coming to the pigment stones are of two types: brown pigment stones and black pigment stones. Brown pigment stones are most commonly seen in India. These are all on whatever the sentence that I am saying, they have been already asked in the MCQs. Okay, most commonly seen most commonly seen pigment stones are brown pigment stones. Most commonly seen in India, also in Asia. And which is the gallstones that are most commonly found in CBD? Again, brown pigment stones. Gallstones that are associated with the infection, again brown pigment stones. The composition of the brown pigment stones are calcium bilirubinate, stearate, and palmitate. This composition has been repeatedly asked, twice or thrice they have asked. Okay, these brown pigment stones are soft, they are radiolucent, they are also seen in the biliary dysmotility, CBD dysmotility. Okay, biliary dysmotility. If at all they are asking which stones are most commonly seen in biliary dysmotility, you should answer it as brown pigment stones. They are also seen worm infestations. Okay, whenever these worms, no, if at all they are entering into the pancreatic duct, they cause acute pancreatitis. If they are entering into the CBD, then they cause cholangitis symptoms. Okay. Black pigment stones. Regarding black pigment stones, there are two to three questions that was repeated in the previous years. These stones has a trait of polymerization, which is these black pigment stones have a trait of polymerization. These polymers are made of insoluble bilirubin polymers. Okay, and what is the composition of these black pigment stones? They are made up of calcium phosphate and bicarbonate. Black pigment stones, calcium phosphate and bicarbonate, and brown pigment stones, calcium bilirubinate, stearate, and palmitate. Make sure that you just remember these things. Okay, they are actually hard and radio opaque. They are seen in hemolytic conditions such as hereditary spherocytosis, G6PD, sickle cell disease, and prosthetic valves. So let's come back to the MCQ that we actually discussed at the start of our class. This 22-year-old man has his spleen removed at his young age. Okay, and he has pallor and scleral icterus. Hence, obviously, this is a case of black pigment stone formation. Okay, due to hereditary spherocytosis. Coming to the mixed stones are most commonly seen in the world. They compose both of cholesterol and pigment content, and they compose of cholesterol and pigment content. As I said, 90% of gallstones are radiolucent, 90% kidney stones are radiopaque, 80% of salivary glands are radiopaque. Okay, how are the patients with gallstones are presented? How are they going to present? Usually, these kind of patients with gallstones, they are most often are females in their 40s, they are fertile, they are fat or obese, and they present after having a fatty diet. Normal proper fatty diet they will have, then they will come with pain. What is the symptoms that what are the symptoms that these patients present with? That these patients present with pain, pain in the right hypochondrium, nausea, vomiting. Okay. What is the typical characteristic type of pain that is noticed in the gallstones? It is said that they have typical biliary colic. Why it happens? Whenever there is stone in the gallbladder, there is obstruction of the cystic duct. When there is obstruction of the cystic duct, patient will have severe pain in the initial stages. This in its intensity lasts for 4 to 6 hours. Once that gallstone comes back into the gallbladder or goes into the CBD, then there is relief in the pain. Okay, so there is a severe increase in intensity and there is a gradual fall. Okay, this actually these patients have pain that usually the pain doesn't even last for more than 24 hours. If at all it is if it lasts for more than 24 hours, then you should suspect other conditions such as acute cholecystitis. What are the signs that are seen on imaging? Actually, gallstones when are if at all when you are performing any kind of imaging studies, we see they have named some signs. Okay, seagull sign. It is seen in biradiate stones have seagull sign, and triradiate stones have Mercedes-Benz sign. The findings of the gallstones on ultrasound has been repeatedly asked. This is very important for the examination. How are the gallstones are seen on ultrasound? On ultrasound, there will be posterior acoustic shadow. Okay, while performing the ultrasound, you can see that they will have a posterior acoustic shadow, and there is movement of the stones. Movement of the stones is one of the important characters seen on the ultrasound. What about polyp? Since we are discussing the ultrasound of the gallstones, well, how are the polyps are going to be seen on the ultrasound? On the ultrasound, these polyps, no, they don't have acoustic shadow also, and there is no movement. What about the sludge? This powdery sludge, just like small powdery structures that are seen inside the gallbladder, they have slow movement on ultrasound. What about porcelain gallbladder? Porcelain gallbladder is actually calcification of the wall of the gallbladder. They have sharp echogenic foci. So if at all MCQs mention about sharp echogenic foci, make sure that you actually answer porcelain gallbladder. We'll discuss these conditions in the subsequent slides. Okay, how are the gallstones are going to be present? How are the gallstones actually present? Gallstones can be asymptomatic. Their patient may have gallstones, but they may not have any symptoms. And patient may present with symptoms. They may present with acute cholecystitis, chronic cholecystitis, acalculous cholecystitis. There can be mucosal, piosal, emphysematous, perforation, gangrenous. In rare cases, they can present with carcinoma of gallbladder. We'll see one by one. Okay. And if at all gallstones are involving the biliary system, CVD and pancreas, they may have acute pancreatitis. So again a question, which is the most common cause for development of acute pancreatitis? Is it alcoholic pancreatitis or gallstone pancreatitis? Gallstone pancreatitis is the most common cause for development of acute pancreatitis. Okay. If there is involvement of the CBD, there is cholangitis, and cholangitis has steps actually. It involves like Charcot striated, and they have named it. It has a Charcot striated and Reynolds pentad. So Charcot striated involves fever, pain, and jaundice, and Reynolds pentad involves Charcot striated plus hypotension or shock with altered mental sensorium. Now they are not asking about what is the constituent of Charcot striated. They are asking which of these fever, pain, and jaundice are most commonly associated or least commonly associated with cholangitis. This is the level of question they are asking. Okay, jaundice is least commonly associated with Charcot striated. If at gallstones, if at all they are passed into the bowel, they may develop, they may present with a small bowel obstruction due to gallstone ileus. Maybe it is an ileus, but it is a misnomer. It is actually a dynamic bowel obstruction, not a dynamic obstruction. Okay. Coming to the asymptomatic gallstones, see, because of increased preventive health checkup, patients may walk to our clinic with the ultrasound report showing that he has gallstone, but there was no history suggesting of any kind of gallstone. He never had any kind of clinical history. So, are you going to perform laparoscopic cholecystectomy for these kind of patients? No, it's not required because the chances of development of asymptomatic progression of asymptomatic to symptomatic gallstones is 20% in 20 years. So it's just like 1% in 1 year. So when are you going to perform prophylactic gallstone surgery? Laparoscopic cholecystectomy. When are you going to prophylactically perform in patients with asymptomatic gallstones? The conditions where we have to perform prophylactic gallstone surgery is when there is gallstone size more than 2.5 to 3 centimeters, because this condition is associated with development of carcinoma of gallbladder. There is 6 to 8% of chances of patients who have large gallstones. Okay, chronic salmonella typhi carriers require the surgery. Porcelain gallbladder is again one of the risk factor for development of carcinoma of gallbladder. And gallbladder polyps with more than 1 centimeter, they also require surgery, prophylactic cholecystectomy, because the chances of development of CHF is more. Patients undergoing bariatric surgery and patients who are immunocompromised, who are undergoing organ transplants, who may receive cyclosporine and immunomodulators, there is increased chances of development of gallstones. Hence, we perform prophylactic gallstone surgery. Do you perform prophylactic cholecystectomy in diabetes? No. There is no required actually. Okay. Coming to acute cholecystitis, the next presentation. What happens in acute cholecystitis is there is blockage of the cystic duct. So the pathology involves inflammation of the gallbladder due to this cystic duct obstruction. How are they going to present these? Most of these cases of acute cholecystitis, acute and chronic cholecystitis, acalculous cholecystitis, these patients present with the right hypochondriac pain, fever, and nausea and vomiting, and the presentations are same. They have Murphy's sign. Murphy's sign is actually inspectory findings, because the patient, when he takes when because of the pain he catches, because of the pain in the right hypochondrium, there is he catches his breath. That is Murphy's sign. When you do the palpation, when from starting from the right iliac fossa, when you go towards the right hypochondrium, then patient due to pain winces and catches his breath. That is Moynihan sign. Okay, what is Bose sign? Boson is hyperesthesia of the inferior angle of the right scapula because irritation of the nerves. Okay. So coming to acute cholecystitis, how are you going to diagnose? Which is the investigation of choice for diagnosing acute cholecystitis, and which is the gold standard? These questions have been repeatedly asked. See, investigation of choice. What is the investigation of choice? A investigation of choice modality should be readily available. It is easily available. It should be cheap, and it should have a little bit of acceptable sensitivity and specificity. What about gold standard? Gold standard should have 100% specificity and sensitivity, and it should have a little bit of uh, therapeutic intervention capabilities. Okay. So investigation of choice in acute cholecystitis is ultrasound. It is not CT. Okay. Make a point and just underline that investigation of choice in acute cholecystitis is ultrasonography, not CT. Okay. What is the gold standard for acute cholecystitis? That is HIDA scan actually. What is HIDA scan? It is hepatobiliary diaminoacetic acid scan. Actually, it is a nuclear study. What happens is in this scan, we inject the HIDA, we inject the dye, and we take serial pictures. So within 30 minutes, usually what happens is when in a normal gallbladder, within 30 minutes, you can see the gallbladder, the dye in the gallbladder. By 90 minutes, you can see the dye in the bowel. But whenever there is acute cholecystitis, because of the inflamed gallbladder, there is no dyes noticed in the gallbladder. This HIDA scan is the gold standard for diagnosing acute cholecystitis. It is actually when HIDA scan clubbed with CCK, it is used for diagnosing biliary dyskinesia. HIDA scan CC with injection of CCK. Okay. What are the USG findings that are noticed in the acute cholecystitis? The USG findings that are noticed in the acute cholecystitis are thickened wall of the gallbladder. But how much of thickness? There should be more than 4 millimeters of thickness. Then there is a reaction in the pericholecystic fluid. So how are you going to manage these kind of patients? These patients are managed according to Tokyo guidelines. As per Bailey, they say like they are managed as per the Tokyo guidelines. Then there is Rome criteria, then there is Milwaukee criteria, then there is Ranson's criteria. But see, Tokyo guidelines is used for acute cholecystitis. When we are not revising properly, this Rome criteria, which is used for biliary dyskinesia, and Milwaukee classification that is used for sphincter of Oddi dysfunction, Ransom's criteria that is used for acute pancreatitis, everything will become khichdi. And if at all you are not revising, you will put Tokyo to Paris, Paris to Rome. Okay, so always make sure that you are revising properly. What are these Tokyo guidelines? This actually grades patients, acute cholecystitis patients into three grades. Okay, grade 2 involves elevated WBC counts with duration of more than 72 hours and patient who have gangrenous or emphysematous gallbladder. Grade 3 is grade 2 only, plus there is some organ failure. Grade 1 doesn't meet criteria of grade 2 and grade 3. How are you going to manage? Grade 1 and grade 2 patients, if at all they are presenting within 72 hours, conservatively manage the patient. Okay, and after the go for emergency laparoscopic cholecystectomy. How are you going to conservatively manage the patient? You keep the patient, if at all there is too much of vomiting, keep the patient NPO, then monitor his vitals, input output charting, then for analgesia you'll give, antibiotics you'll give, Folis if required, we will catheterize the patient, and we'll conservatively manage the patient. Once the patient settles, then we'll take the patient for laparoscopic cholecystectomy. These kind of patients who undergo laparoscopic cholecystectomy for acute cholecystitis, the chances of you patient going for open cholecystectomy is more. Chances of conversion to open is more. Usually it's around 5%. In this patient, chances of open cholecystectomy is slightly elevated. If the patient presents after 3 days, what are you going to do? We just manage just like acute appendicitis, conservative management, Ashna-Sherling regimen. Okay, so the Ashna-Sherling regimen is for acute appendicitis, not for acute cholecystitis. Okay, if these patients present after 3 days, we'll do conservative management, discharge the patient, we'll perform interval laparoscopic cholecystectomy after 6 weeks. So I have been mentioning about laparoscopic cholecystectomy. If at all there is a question asking which is the gold standard treatment for gallstones, then it is laparoscopic cholecystectomy, not open cholecystectomy. For Tokyo grade 3 patients where there is organ failure involvement also, organ failure if at all it is seen, then we do percutaneous cholecystostomy. We insert a tube into the gallbladder percutaneously, and once the patient is settled, we'll take the patient for surgery. What about chronic cholestatis? Chronic cholestatis is multiple episodes of repeated acute cholestatis. These patients on ultrasound has wall echo shadow due to thickened wall, which casts a shadow on the ultrasound. The HP of these patients after performing cholecystectomy actually shows Rokitansky's sinuses. Okay, what are these Rokitansky's sinuses? These are all deep outpoachings in the gallbladder wall that can extend into the muscular coat and perimuscular layers. If these Ascoff sinuses are ruptured, they lead to development of xanthogranulomatous cholecystitis. Okay, but remember that xanthogranulomatous cholecystitis, which actually develops from the rupture Rokitansky's Ascoff sinus, is a non-infectious condition. What about xanthogranulomatous pyelonephritis? It is an infectious condition, and it is developed from most common cause organism causing is Proteus. Okay, and we'll see some MCQs. Which of the following is not an USG finding in acute cholestatis? They're asking which of the following is not an USG finding in the acute cholestatis. So do these patients have absence of gallstones? Yes, there are certain. There is no Bible this thing that there should be presence of gallstones always. So there can be chances, there can be cases where there is absence of gallstones. Okay, and there can be reactionary pericholecystatic fluid that is seen, and there can be sonographic Murphy's sign. What about the thickness? Gallbladder wall thickness should be more than 2 millimeter. Should be more than 4 millimeter, not more than 2 millimeters. When are you going to perform prophylactic cholecystectomy? Except they are asking. So always make sure that you don't miss except only one other things. Okay, so only one if but these are silly mistakes, they should not perform. Okay, so that's why read the questions properly. The question is prophylactic cholecystectomy is performed in all except will perform prophylactic cholecystectomy in all transplant patients. Incidental gallstones and laparotomy also require cholecystectomy, sickle cell disease, but not in diabetic patients. Which of the following are not true for the emphysematous cholecystitis? What is emphysematous cholecystitis? Just like it is actually caused by Clostridium. We'll discuss this condition. I'm just giving MCQs, okay, right now. What happens is, so that's why I'm telling, that's why I say always solve the questions first, then go to the theory. When I explain about emphysematous cholecystitis, obviously this seems very easy question to you. Now, right now, when I haven't explained it, it seems very difficult, okay? So which of the following are not true for the emphysematous cholecystitis? They are usually associated with acalculous cholestatis. Yes. Okay. And most commonly seen in diabetes mellitus. Yeah. Is it? Yes. They are usually seen in more diabetes mellitus patients. Okay. Uh, it is usually caused by Clostridium. The emphysematous, as you know, gas in the gallbladder. Where do you see the gas? The gas is actually seen in the wall of the gallbladder, not in the lumen of the gallbladder. Okay. So for this question, the answer is air is seen in the lumen of the gallbladder. Okay. This is the wrong answer. So in emphysematous cholestatis, usually associated with acalculous cholestatis, they are associated with diabetes and usually caused by Clostridium species. Okay. Rest we'll discuss in the subsequent classes if given chance. Okay. Thank you.